Anatomy and imaging of the wrist. We're going to start off with some surface anatomy and some bony landmarks that you can feel on your own wrist as we go through the talk. Firstly, the radial styloid, very obvious, rounded bony prominence at the base of the thumb. Secondly, Lister's tubercle is felt on the back of the wrist, and this is the tubercle around which the EPL tendon runs. Just distal to the Lister's tubercle is the surface marking of the scapholunate joint. The distal radial ulnar joint is also palpable on the back of the wrist, and particularly if you pronate and supinate the forearm, you can actually feel this joint. And don't forget that intra-articular fractures of the distal radius can go into the radiocarpal joint, but they can also go into the distal radial ulnar joint. The knobble on the back of the ulnar aspect of your wrist is your ulnar head. It is not your ulnar styloid. The ulnar styloid lies more volarly. And if you feel your ulnar styloid and your radial styloid at the same time, the radial styloid should be about 1.5 centimeters longer than the ulnar styloid, which is a particularly useful thing to use when you're assessing your reduction of distal radius fractures. This is an anatomical specimen showing the dorsal extensor compartments of the wrist. And the placement of K-wires is important as far as this is concerned. And if we look at a transverse section through this anatomical specimen, it looks like this, with the radius highlighted there in black and the dorsal extensor compartments highlighted there in blue. Now there are 3 areas where it is safe to put K-wires, and these are illustrated here, in between the first and second compartment, in between the second and third compartment, and in between the fourth and fifth compartments. There's 2 other ancillary areas where you can put K-wires, and those are volar to the first dorsal extensor compartment, but you've got to be a bit careful about the radial artery here. Also between the third and fourth compartment, but you have to be a little bit careful about the EPL tendon that tends to go transversely across the wrist here, so it's more likely to get pranged. This is a slide showing the surface marking of the distal radius in blue, and also where the radial nerve lies. And you can see that it's got a dorsal branch and a volar branch, and there's a V, a safe area in between those 2 branches. The radial nerve at this level is a purely sensory nerve, and it's a really good idea to avoid purely sensory nerves because damaging them causes significant problems. And this triangle of safe area is illustrated in this anatomical specimen here. But you must be aware that no K-wire is more than 2 millimeters away from a branch of a nerve or a tendon when you're K-wiring the wrist. This illustrates the volar approach in between FCR and the radial artery. This is the modified Henry approach, and I'm sure you're aware that Henry's original approach was radial to the radial artery. On our anatomical specimen here, you can see where the radial artery is here illustrated in red and the FCR in blue, and the approach is in between those 2, straight down onto pronator quadratus. The dorsal approach is through the base of the third compartment and is illustrated on our transverse section here through the base of the third compartment, either going radially underneath the second compartment or ulnarly underneath the fourth compartment. Imaging. Now, imaging should be used to supplement your clinical findings. It should be used to confirm a diagnosis and not make one. What modalities do we have? Well, we have plain X-ray, ultrasound, bone scan, CT scan and MRI. I've put the plain X-ray in a larger font because I think it is the most important modality that we have. There are some angles that you can measure on your plain PA X-ray of the wrist. There is a radial tilt, which should be 22 degrees. There's a radial length between the radial styloid and the most ulnar aspect of the radius, which is 11 millimeters. And if you look at the lateral view, there is a volar inclination of 11 degrees. So there is a rule of 11s here. 11 degrees of volar angulation, 11 millimeters of radial height, and double it 22 degrees of radial inclination. On the PA, you can also assess ulnar variance. If the ulna is longer than the radius, radius, it's called positive ulnar variance. If the ulna is shorter than the radius, it's negative ulnar variance. And there's normally about a 2 millimeter variation. That's what the normal finding is. On the lateral X-ray, we can see 3 cups. The first cup is the distal radius. The second cup is the proximal aspect of the lunate. And the third cup is the proximal aspect of the radius. Now, this lateral view here is not a perfect lateral. A perfect lateral should have the pisiform covered up by the scaphoid. You can measure a scapholunate angle between the axis of the lunate and the axis of the scaphoid, and that angle should be somewhere between 30 and 60 degrees. If the lunate faces north or dorsally, it's a dorsal intercalated segment instability, or a dizzy, where the scapholunate angle will be more than 70 degrees. If the lunate faces south or volarly, it's a volar intercalated segment instability, or a visi, where the scapholunate angle is less than 30 degrees. When you look at the carpus, there are 3 lines. These are called Gilula's lines. The first one is on the proximal aspect of the proximal carpal row. The second one is on the distal aspect of the proximal aspect of the carpal row. And the third one is on the proximal aspect of the distal carpal row. These are like the Shenton's lines of the hip. And you can see on the left here, where there's a scapholunate disruption, Gilula's lines are broken. You see on the slide on the right, you'd think, well, it doesn't look too bad, but if you actually draw the lines in, the Gilula's lines are broken again, and there's scapholunate pathology here. You can measure the carpal height, which is the height of the carpus measured from the base of the middle finger metacarpal to the distal radius. You can also measure the carpal height ratio if you divide the original figure by the third metacarpal length. Beware the other side. There's a case report of a 25-year-old chap who fell abroad, arrived in plaster of Paris, he fell on his outstretched wrist and there was alcohol involved. He was told when he went abroad that he may need an operation when he comes home. This was his X-ray, or a series of X-rays, and you can see that there's a dizzy deformity. Now, he didn't seem that bad clinically to me, so I X-rayed his other wrist, and you see the other wrist has got a dizzy deformity also. So this is a normal finding, and he really didn't have a lot wrong with him, and he didn't need any formal treatment. So what about other modalities? Ultrasound. This is useful for tendons, particularly tendon ruptures, also soft tissue masses. The pros are that it's cheap, it's very good for children, and there's no radiation. The cons are is that it is very, very operator dependent. It's also not very good for bone. A bone scan, what are the indications for a bone scan? Well, trauma, bone lesions, pain, query cause. So if you've got a painful wrist you don't know the answer to, bone scan may help you. Or diagnosing CRPS, potentially. Bone scan is sensitive. If the bone scan is normal, your wrist is likely to be normal. The cons are is that it's non-specific. You may get a hot spot over the distal radius, and this could be distal radius, it could be a scaphoid fracture. There's also a high dose of radiation. It's equivalent to a barium enema, so it's a significant amount. You can then perform arthrography, and this is very good for soft tissue things like TFCC tears and scapholunate tears. And we now use arthrography in conjunction with both MR and also CT. But don't forget the original arthrography findings. Sometimes you can find the similar findings that you find in your pathological wrist to your unpathological wrist, so it's a bit like the X-rays. CT scan, the indications for this are diagnose fractures, assess whether a fracture is intra-articular or not, tumours or cysts, DRUJ incongruency, and assessing union. Example of a distal radius fracture here, and I was slightly concerned on the lateral view. This may be an intra-articular fracture. I did a CT scan and found that it certainly was, and it was much larger fracture than I thought it was. It also helped me to know to operate on this fracture from the back. So it was a very useful investigation. Changed my practice. CT scans have pros. It's great for cortical bone detail. There are thin sections. It's also really quick. The cons are is the fact it's poor for soft tissue, don't see bone edema, and if you can miss the fracture plane, particularly in scaphoids. So the CT scan of the scaphoid has to be done in the plane of the scaphoid. The MRI scan has indications for fracture diagnosis. I use it quite a lot in diagnosing scaphoid fractures. Bone edema, ligamentous injury, AVN and tumours. That's an example of a scaphoid fracture on an MRI. Pros, it's great for soft tissues. It gives you thin sections in any plane and there's no radiation. The cons are is that if patients have any metalwork in, that can stick to the magnet, which is potentially can be a bad thing. It's not good for claustrophobic patients, and it's expensive and it takes a long time. I've had an MRI scan of my wrist, and I was in the MRI scanner in an exceedingly uncomfortable position, in the swimmer's position, for 45 minutes. So in summary, investigation should supplement your clinical findings. You make the diagnosis first, then you confirm it. The plain X-ray is the most useful. There's no ideal investigation, and always beware that you may have to X-ray both sides. Thank you.